strategies, but also probably the more important ones, the non-pharmacologic ones too. As far as any disclosures, obviously a lot of these medications are off-label that we're going to talk about today. So that's my only major disclosure there. For the objectives, again, we'll recognizing those symptoms is probably the most important step. And then what to do about them is the next step. So I'm going to mention the idea of incorporating a multidisciplinary approach as well. And then we'll go over kind of, when to use medications and not. So I think first as a background, right, I think most of us that deal with patients that have progressive cognitive diseases like Alzheimer's disease or Lewy body disease, right? Neuropsychiatric symptoms of those disorders is very common. So depending on the study you look at, somewhere between 80 and 95%. Some people even say 100%, but a good majority of our patients are going to develop some of these symptoms. And it's actually one of the two most common reasons for placement. So as far as caregivers being able to manage these symptoms and loved ones, that's usually the line rather than just memory symptoms. It's important to note that as patients progress in these disorders, they have a high rate of depression, but that often goes unrecognized. They're not going to say, I feel depressed. If you have them fill out the PHQ-9, they're probably going to have a 0. And part of that might even be down to brain biology of these changes that are happening in the brain. But those that do have depression have a higher rate of transitional trauma as they're sort of switching between these living arrangements and dealing with the disease at a point of diagnosis too. These complications are associated with greater impairment in tasks of daily living, as well as more rapid cognitive decline. So when you see someone developing behavior symptoms, that is an indicator of potential worsening of cognition as well. It results in worse quality of life as well. And then, as we mentioned earlier, that kind of earlier institutionalization. So there's a lot of issues with facilities being equipped to handle these symptoms too. So this results in a lot of different movement, to undesired locations or unfamiliar locations that kind of causes almost what we see as far as a spiral downwards, right, of as a patient progresses in these disorders. And we know that these are highly correlated with caregiver burden and depression as well. And so that's an important thing to keep in mind. So I mentioned this earlier, but depression often goes unrecognized. And it's often not just what we see in someone in middle age as far as when they're, or even earlier age, if they're suffering for depression. This usually results in more of an anxiety and agitation symptom. Oftentimes our patients are, they recognize that their symptoms of memory are impaired, right? And they get frustrated with that, or they get frustrated when the caregiver says, we already talked about that, right? And then there's a little battle that happens there. And that's where that irritability and agitation comes from. So some clues to that is maybe patterns or worst times of the day, that sort of variable mood with excessive irritability, especially when that memory is questioned. Or another one is when the routine is broken. So patients that are sort of reaching that dementia stage of these disorders, routine is vital, right? And then when it's broken, they don't have that flexibility to deal with that change. And I will say that SSRI medications can help. So Michelle Needens, who leads our cognitive care network team, that's oftentimes one of our battles is just getting an SSRI started. And then we sort of get this pushback of, well, they're not their PHQ-9 is normal, or, if you're noticing these symptoms of behavior changes, you got to at least try some of these. And that's what we're going to talk about. So as far as a case, this is more of I wanted to introduce a case like this because we don't have a specific talk on it. So if you ever see a patient coming in with progressive personality changes, right, that's kind of what this case represents. They were laid off work, so they were working during this. Part of that was that troubles completing tasks, similar to, those earlier dysexecutive or young onset Alzheimer's cases. But in this case, there was some other important details. So they were kind of making unusual comments to coworkers as far as their weight, race, politics. These were unusual for this individual. Once they got laid off, they basically sat on the couch all day, smoking cigarettes, started consuming multiple liters of soda, so some major dietary changes. And then, at that point, reasonably so, they were diagnosed with severe depressive disorder. On their exam, so they really had no insight into any of these problems. All this history came from the daughter and what she had kind of learned talking with others. On my bedside screening, so the short test of mental status, almost normal. So 35 and higher is normal. She was 34 out of 38, and did fine with the memory portions. Just knowing that I wanted to test the frontal lobe a little bit, I did this 1 minute. How many words can you think of that start with the letter C? So that tests the frontal lobe a little bit better. And she only got 4, which we really expect to see higher than 11 in her age group. We talked about this with another case, but where you do sort of have them do a sequence of 3 things, and they're supposed to be able to mimic that and then not able to do it on their own. She really struggled with that, which tests a little bit of that executive network. Otherwise, pretty normal exam. And so, I think as far as when we think of like, how do we screen for these things, right? There's lots of things we can ask a patient. We don't always have time to go through everything, right? But if there's concerns for behavior changes, then you might want to focus in on asking those types of things, right? And then noting things in your note of lack of insight and maybe rude behavior. There's a couple different tests you can do too. But really asking those questions and delving a little bit deeper is how you can sort of figure out, is this maybe something different than a typical Alzheimer's patient? On their brain scan, so the front of the brain is here, back of the brain. You can see sort of it's divided into 2 halves here. So all this gray stuff is the normal brain. The read was mild vascular disease, which I would agree with. She's got vascular disease that are these little white spots. But otherwise, it was read as a normal brain. Other than that, the memory structures look fine, which is why she's doing fine on my testing. If I scroll back to the top, there may be subtle changes happening here in the frontal lobes, more on this image here. So, with her history and with sort of what I was seeing on the scan, I was like, well, we should probably do something a little more objective here and get a better answer. So we proceeded to get an FDG PET scan, which I've shown you some of these pictures in the past, but for anybody new, gray is normal on these scans, and we're looking at glucose metabolism. So how well is their brain using the glucose? And this is like a front-on view here, and the more colorful things are, the more abnormal. And you can see the right half over here and the left half, much different than the back part of the brain. And you can really see it on the right front here versus the left front. And so this basically helps us understand that the frontal lobes are not working very well. And this helps us move into sort of a probable behavioral variant FTD rather than, sort of a possible is where I was at beforehand, right? And so this behavioral variant FTD, we sort of use the short-term BVFTD. So what does the frontal lobe do, right? How can we make sense of this? Well, it's important for executive function, right? So your ability to plan, make decisions, judgment. Patients are at high risk for scams when the frontal lobe is not working well. Cognitive flexibility, so those problems of changing from routine. It can mess with processing speed on our cognitive testing. And it's also, I refer to it as the filter, right? So, what are the consequences of saying what's on my mind, right? And so that can lead to socially inappropriate behavior, impulsiveness, careless and rash decisions. And so you can see that there were clues on that MRI scan, but if you're going off the radiology read, which very reasonable for most of us in a busy clinic that aren't behavioral neurologists, that there is that extra step, right? And that's where that PET scan comes in to try to help to get a more definitive diagnosis. Clinically, though, recognizing it and asking the right questions, there are clinical criteria that can at least move us into that possible BVFTD, right? You need to have 3 of these 6. So behavioral disinhibition is that filter we talked about, all those examples there. Apathy or inertia. So she was basically just like, she was somebody that was pretty active before and was just sitting on the couch smoking cigarettes, right? That was a major change in her sort of, it was a lack of drive and apathy. And an early loss of sympathy and empathy can be one. So, a family member dies, a friend of the family dies, and all of a sudden, they're unfazed by it. They don't even kind of acknowledge that there's a loss that's happened, right? That's a major change for some individuals. And then early perseverative or stereotyped behaviors. Hyperorality and dietary changes are a thing to ask about. So if she was drinking liters of cola or Pepsi, I think, which is a change. And then when you do get neuropsych testing, we're looking more for a executive impairment more than memory and other domains. I do have to highlight, because any neuropsychologists in the crowd, or if you do get the reports back, executive predominant dysfunction is not always FTD, or especially not BV FTD. So we can see executive problems in Lewy body disease and in early Alzheimer's, the early onset type of Alzheimer's disease. Really, the history of kind of these behaviors is usually the differentiator for me. So even though they might have some anxiety and maybe some apathy too, their general social warmth is usually present. They tend to have more insight. But again, this is another role of a PET scan. Whereas in our young onset Alzheimer's disease cases, the epicenter is really this parietal lobe here, but the frontal lobe is certainly involved. And that's where it gets complicated, deciphering between an FTD and one of these atypical AD cases or Alzheimer's cases. So the main point of our talk, so I wanted to have a FTD case, because we especially a behavioral one, because we don't have a specific talk on that. So a lot of this management that I'm going to talk about next is focused on FTD, but then we'll have some wrap-up slides of just behavioral symptoms in general and management for that. Because there are a few slight differences that you have to keep in mind for patients with Lewy body disease and Alzheimer's disease. So this disease is probably the most difficult out of well, there's a couple that could match it, like Huntington's disease. But as far as what we more commonly see, it can be very difficult for loved ones to deal with. And that's due to the lack of insight and the behavioral symptoms that accompany it. And oftentimes it's that delay in diagnosis that there's lots of things happening that don't have an explanation, which can lead to, marital problems and estrangement from family and friends. That sort of those years leading up to that diagnosis, there can be a lot of scams and financial chaos going on, excessive buying of things, and some major damage from a financial and relationship standpoint. It's about 50% of patients with FTD are diagnosed with psychiatric disorders for years leading up to it. And that's also true for patients that actually have psychiatric disorders. FTD is sometimes misdiagnosed there too. And I think that's where at least getting the more detailed testing with neuropsych, but then also thinking about if you're unsure, that would be a role for a PET scan and a referral to our clinic to help differentiate that. Information, getting a diagnosis is the first step, because then that can plug individuals into information. Education is sometimes the best approach to, hey, this is why this is happening, right? And these are things that you can be doing to try to, at least reduce the risk of these things. And that support for caregivers is vital. So, we talk about our cognitive care network team, but that's really any social worker in your community that is working with our cognitive care team to help train them on these types of disorders. And these things are, we have support groups for caregivers, and also just a lot of strategies to help them at least try to manage these symptoms. And so, that's where these non-pharmacologic strategies come from. So some medications can make symptoms worse. There's no FDA approved treatment for patients with frontotemporal disease. Donepezil can actually make some of the behavioral symptoms worse, because these patients aren't at a cholinergic deficit. So sometimes we see worsening of those symptoms. And then SNRIs can sometimes increase agitation and compulsiveness with that extra norepinephrine. When we look at kind of the Band-Aid approach, right? So some, I think of the Band-Aid approach as kind of like an as needed, or, hey, it's getting really bad, we got to give them something, right? Typical antipsychotics have been sort of the mainstay for that. If you look at really the last few decades, things like haloperidol or olanzapine, those sort of dopamine blocking antipsychotics you do have to keep in mind that some of our FTD patients have Parkinsonism, and those symptoms could dramatically worsen if you give them a dopamine blocking agent. Benzodiazepines are often used too. And so that may actually be necessary for excessive issues, right? Especially when there's violence potentially involved with the aggressive outbursts. But you do worsen their chance of it actually worsening their cognition and confusion and balance, right? And this is definitely not a good long-term solution as our patients get older. For kind of focusing down on specific behavioral symptoms. So agitation-wise, from a non-pharmacologic standpoint, there's many things to think about. For patients that are in nursing homes or at more advanced stages, maybe they can't communicate very well, right? Screening for pain is important, and if even trialing some doses of Tylenol, because sometimes agitation is actually related to unrecognized pain. And then trying to alleviate that agitation with scheduled activities, right? So a lot of times this is out of boredom and the brain sort of looking for some sort of outlet, right? And so music, exercise, a lot of structured activities within facilities can help alleviate some of these agitation symptoms. From a pharmacologic standpoint, more for FTD, paroxetine or Paxil is probably the most well-studied. And then trazodone can be more of the as-needed agent at very low doses. We are looking, so there's an interesting lithium randomized controlled trial going on right now. And then cannabinoids may be a reasonable alternative, especially for nighttime type issues, because these can maybe help with sleep as well. And then there's a couple anti-epileptics that are being investigated. From an apathy standpoint, right, a lot of that is getting some sort of tailored routine built in from a non-pharmacologic standpoint, right? So structured routines with good cueing, if you just say, hey, do you want to go do this? The answer is going to be no. Hey, we're going to go do this, and this is why, right? And having some sort of buy-in with that is important. From a pharmacologic standpoint, though, there's not many great options. We're looking at some of these stimulant medicines, right? And there may be a role there. You do worsen, agitation or aggressive behaviors in some patients. So it kind of depends on what exactly their symptoms are. Some of the future directions here, I think modafinil might be a better agent. So that's being studied. And then actually oxytocin is being studied a little bit as well. For empathy and sympathy, really that's mostly educating the family member and the caregivers, the loved ones, because understanding that this is not, they're not doing this for a specific reason, or they don't dislike this person. This is just part of the disease, right? So sometimes that education is enough to help understand that for the family. There's really no pharmacologic treatments for that, unfortunately. Interestingly, oxytocin is being looked into for this too. That's thought of as the love hormone, but if you've got patients that have sort of increased sexual desires and things like that, that would not be a good option for them probably. So to be continued on that one. Just mentioning that sexual behavior, because that can be something we see in patients with FTD, or at least frontal lobe involvement of cognitive disorders. From a non-pharmacologic standpoint, trying to avoid those situations is important. So if it's one certain individual, and it's usually like, if they're having to watch this individual for some time, I think, just trying to avoid that, and having someone else present can be important to try to avoid this type of behavior. Sometimes it's just a lot of excessive asking for sex. And so we try to utilize some of the side effects of the higher side effect rates of SSRIs for decreasing libido. Citalopram seems to have the highest rate of that. And so this is also pretty well studied in FTD. So that's one to consider. I didn't put on here that some people will try hormone replacement therapies. I haven't seen any good studies on it. I've personally not tried it, but I've seen, some psychiatrists trial, trying to increase estrogen. Although those things get a little difficult for me to understand. Is that going to get converted to testosterone? But I think some ongoing studies are interesting in that regard. For compulsive behaviors, so really, so these can be, I've seen a lot of skin picking at later stages, right? So A lot of times it's more of clothing barriers for that, distractions, replacement activities. I mean, for severe dementia, there's even things like distraction vests, and try to prevent them from self-harm. Sometimes we get some patients that compulsively drink water to the point where it's actually dangerous. And so kind of having the water shut off, or limitations for that water intake is the non-pharmacologic strategy for that. We do OCD, obsessive compulsive disorder. We use high doses of sertraline and other SSRIs in those disorders, and they can be helpful for some of these behaviors. Interestingly, some of the atypical antipsychotics can worsen them. There's some ongoing studies in transmagnetic stimulation, because this is approved in OCD now. Obviously, we're dealing with a slightly different substrate with degeneration of the frontal lobes, but I still think it's interesting line of research. For hyperorality, so we'll see this often. We had this in our case with the increased soda drinking. I know it's not always, it's easier said than done, but limiting access is really the mainstay of treatment here, right? So whether it be locks or hiding, or just not having those things in the household, or limiting that access. If they get a craving, maybe there's a healthier alternative that they'll eat. If they eat a bag of carrots, that's less harmful than the donuts and things like that, right? Scheduled treats in limited amounts can at least help a little bit, but this isn't always driven by hunger, right? And then some will get so restrictive with their diets, like same things over and over. Vitamins and other supplements may be needed. From a pharmacologic standpoint, interestingly, topiramate has at least some amount of an appetite suppressant. So it's something that can be considered, but as our patients are getting progressive cognitive disorders, it can have side effects of cognition, and especially word finding difficulties. I think I've only used it in about 1 or 2 cases. But again, SSRIs and trazodone are kind of our mainstays there, other than the non-pharmacologic. Modulators of metabolism are interesting, but again, not all of these things are being driven by hunger. So I'm not too sure if that'll pan out. For psychosis, so this is a larger category, but delusions, hallucinations along those spectrums of things, very, very common in our patients, especially with Lewy body disease. But oftentimes asking, what are those triggers? What time of day is this happening? What tends to be a trigger, right? Trying to solve that issue first, or have the caregiver and loved one solve that issue first. Because avoiding those triggers is probably the best treatment, right? So I had a patient, a couple of weeks ago that was having visual hallucinations of Ukraine children, like in the living room, right? And really, one of those strategies is to limit TV watching, especially of distressing events, right? And then that can help those distressing hallucinations go away. For pharmacologic treatments, so we can use trazodone. I tend to use quetiapine, or what's called Seroquel, for the paranoia associated with psychosis. Trazodone is more for the anxiety. And again, any SSRI here would be something to consider as well. Olanzapine listed here as a dopamine blocking agent, so wouldn't be my preferred agent. Again, future directions here. One that I mentioned is pimavanserin. So that is approved for Parkinson's related psychosis and hallucinations. So that's an interesting one to keep on the radar. For sleep, so there's many non-pharmacologic things. We'd have a whole talk on that, right? People's sleep hygiene is not ideal in many situations, right? But even sometimes just things like increasing physical activity can help. If you have a more a typical exercise regimen planned for them throughout the day, that can help promote sleep too. From a pharmacologic standpoint, I always stick with melatonin first, and then if that's not working or not enough, then we add in low doses of trazodone and titrate up more for that bedtime dose. And then you can utilize, depending on what's keeping them up, like a mind racing phenomenon, right? That's usually underlying anxiety. So those are the other options. And then there are some orexin modifying agents and other agents that are actually FDA approved for sleep disorders, but just how safe are they in this patient population, we don't quite know yet. For longer term situations, right? So we mentioned sort of that Band-Aid approach, the longer term approach. I just wanted to kind of summarize these in a couple slides for you, right? So if we specifically look at FTD, paroxetine or Paxil seems to do better there. The interesting thing about proxy, even though it is listed as an SSRI, it has pretty strong anticholinergic properties. So it's not a good choice for our patients with Lewy body disease and Alzheimer's disease. And citalopram has a very clear warning that it shouldn't be used at higher doses with donepezil. So that might not be your best option for these patients either, since we want them on donepezil. From a Band-Aid standpoint, trazodone, I usually use it for that agitation, irritability, anxiety side of things. And you can give this at nighttime, for sleep, but we're really using much lower doses for those daytime symptoms. So we're talking 12.5, usually 25 milligrams, kind of split in different doses throughout the day. And that would be much preferred over something like a benzodiazepine. For quetiapine or Seroquel, again, I use that more for paranoia-related symptoms. There is the black box warning you have to warn patients about, especially if they got any cardiac history or are on other QTC prolonging agents. We recommend an EKG before starting. But in most cases, the benefits outweigh the very low risks, somewhere below 1% for increased death in patients with dementia. And it's just important to always start low and go slow in these individuals. And so we're talking with doses as low as 12.5 milligrams. Just to kind of round out, because I don't want some of this to get lost in other dementia disorders. Our Lewy body patients have lots of behavioral symptoms. And so nothing changes there from the trazodone standpoint. But as far as the SSRIs, I typically use escitalopram or sertraline. I tend to not see good success with SNRIs. Sometimes that can worsen behavioral symptoms, and we talked about why not to use paroxetine. For these psychosis, delusions, hallucinations, again, the quetiapine seems to be best there. Really, it's more of just also making sure you do not use dopamine blocking agents. And then I think from a long-term standpoint, starting donepezil is by far and away probably the most successful thing, especially for hallucinations. And then we're utilizing pimavanserin more once it's at least a little bit more affordable. And so those agents seem to work much better for a long-term perspective. And most of these principles hold true for patients with Alzheimer's disease too.